We are very excited to have you all here this morning, and we're incredibly grateful for your time. We do understand that none of you really want to be here. Okay, we understand that none of you wanted Sjögrens. We understand that actually this probably wasn't part of your planning, as you went through your life. And we understand that your journey to get to this point has possibly been very difficult, and you faced a lot of challenges along the way. Okay, so that's the first thing. So we just want to make it clear that we understand that all things being equal, all of us would like this room to be empty, and we would like nobody to experience the symptoms and the disease, and that we're learning so much about from people like you and from our collaboration with the Sjögrens team. But we are very determined to work together to try to make things better, and I'll explain the things that we're going to work on. But part of it is getting the message out there, and I think what's not been done so well, and something that we need to work on as healthcare professionals, is making sure that we're sharing stories, that we're getting the information out there, and that you're not faced with the same experience of having to explain Sjögrens to every single person that you meet, even when you're not feeling so well. So with that in mind, we're hoping to keep the social media very active today. The Sjögrens community online is wonderful, as we know from Sjögrens Ireland, and also members of different international US and European networks. And then we also have an RCSI hashtag, and the purpose of hashtags is to get these messages picked up across as many places as possible. So if anybody is on social media, please do use those. And also we have a range of social media options for people if you'd like to stay connected with the project, and Sjögrens Ireland will have all those details as well. So you don't need to remember this, we can share this afterwards. So what brought us all here together is the SYNERG-IE program, and this is a project that we co-designed with Sjögrens Ireland, so we're very delighted to work with them. The name reflects the team, so I'll give you the core staff and the core team in a minute. But essentially, we're a blend of healthcare professionals and researchers with very, very different backgrounds. So I'm a pharmacist by background. We have Owen, a consultant. Connie's a dentist. We have Maria, who's a psychologist you'll hear from this morning, because we understand that this disease is not something that's simply treated by one person. So we were awarded, and we're very grateful to the Health Research Board, who gave us €2.5 million last year to spend 5 years trying to do our best to make this better for you. Okay, and that's very much what this is all about. Through working with Joan and Sjögrens Ireland, we were able to identify some priority areas. So some of you might be familiar that Joan and Sjögrens Ireland have worked together for years, focusing on the lab-based research that will hopefully bring, the scientific breakthroughs that we like to see and we need to see in the pipeline. I'm by background a health services researcher, so I look at how the health service is delivered and how patients experience health services. And while we wait in great hope, and Owen will talk later about the potential therapies that are potentially coming available, we have to do something now to help. It's not good enough to say, hopefully in 10 years we'll have a cure. There's people like yourselves experiencing Sjögrens at the moment, and we know, because we've learned from Sjögrens and people like Sjögrens Ireland and people like you, that it's not good enough. And it's not fair. So these are the challenges that we'll be working on over the next kind of 5 years. We need to understand how to improve medicines are used and prescribed for people living with Sjögrens so that they're most effective, but also importantly, so you're not prescribed other medicines for other conditions that inadvertently make your Sjögrens worse. And we know that happens all the time because lots of medicines have side effects that just make, all the Sjögrens symptoms worse. And we need people to know about that. We understand your experiences. We ask you to share them with us in lots of different ways, but we need to formally report that to make people listen, because unfortunately there's, specific formats that researchers and healthcare professionals are used to receiving information. So we need to document this formally, and we need to put it in front of people and say, this isn't acceptable, this needs to change. We really need to educate current and future healthcare workers because, we've learned from working with you guys that it's not, it's not fair when you're sick to have to say, and actually the disease is serious, it's systemic, I experience it like this, or to have somebody dismiss your symptoms and say, you're just stressed, or you're, what else is going on. So education is a key focus as well. We need national guidelines and policies for Sjögren's care so you can make sure you're getting the best care that is available for you. It's, people understand what it is, and we're specifically focusing on primary care because you'll hear from Owen, a rheumatologist, later who knows all about it. But a lot of the people you will see day to day is your GP, your pharmacist, your physio. We need all those people to understand as well. We know that lots of you won't just have, experienced Sjögren's, you'll live with other diseases and they all overlap. So us looking at Sjögren's only would be, a bit silly, given we know that a lot of people will have rheumatoid arthritis and other things going on as well. So we look at how they all interact together. And then we need to partner with people like you throughout, because I know about medicines, I know about research, I don't know what it's like to live with Sjögren's. And unless I understand that, I won't be able to do the best possible research to help for the best possible outcomes. So that's why we're going to work with Sjögren's Ireland and our PPI partners throughout. And we do need you to help us. So we will be reaching out saying, look, we need your stories, we need you to give us the information that we can put in front of the HSE and policymakers and say, this needs to change. And without that, sometimes you can feel a little bit, like you're not, you don't have the evidence or you don't have the hard facts to show. So I'm not going to, kind of dwell on introducing everybody, because as Nikki said, we'd love for you to meet us all today. We're all here, probably most of us wearing a red lanyard with our name on it. So I'm the lead of the project. Frank, who is at the back, just keeping an eye on the Zoom, is the co-PI. McCarthy's going to speak with us later. He's a rheumatologist in Beaumont. Our key partners are Sjögren's Ireland, and we do nothing without them. Nikki's program manager, Gráinne, is a patient researcher. So she's actually employed by RCSI and works with us alongside us every day. And then we have the team who have given up their other jobs and moved countries in some cases to be with us to work on this project. So they are the full-time staff. So we have 2 PhD students, a designer. Connie is a dentist and an epidemiologist by background, and Maria's a psychologist and a qualitative researcher. So they've all decided to leave their previous roles and come and work on this full time because they're very motivated to make things better for you. Our PPI panel is being established at the moment, and they will be working with us closely as well. So essentially, what we've set out is a very ambitious plan to make things feel different for you. So instead of you having symptoms and being sent around the houses, people will recognise what's wrong with you and refer you quickly to avoid unnecessary delays that lead to damage. You'll be advised to contact support immediately. So people like you that understand the disease, and that's why we've placed an emphasis on networking. There is nobody that will be able to help you better than people who understand the condition. All of the people and healthcare professionals who treat you will understand what the disease is and know what it is. So you will not have to be put in a position of education, that your treatment is evidence-based on guidelines, and that you have ongoing opportunity to support the research that underpins your care. So that's our goal. It's quite ambitious, but we're very dedicated to making it happen, and we have a great team in place to do that. So speaking of great team, I am very delighted to hand over to Sjögren's Ireland, who've been really key in making this all happen. Initially through the partnership with Dr. Joan in Dromgoole, who's a senior lecturer and principal investigator in the School of Pharmacy and Biomolecular Sciences at RCSI. So really thrilled for them to have the first word, because that is really what matters here today. All right, thank you everybody.
Great, thanks. It's great to have so many people here in the room and so many online, and Michelle did a great job of all the things that have very long names. So she's already introduced me, and I have the pleasure to introduce our panel. So these are our Sjögren's Ireland founders. So I'm going to start with, as you see our panelists in front of us, I'm going to start with Deirdre. So Deirdre Collins is an archaeologist whose career ended due to Sjögren's. She's had symptoms of Sjögren's since childhood, and she founded Sjögren's Ireland in the hope that it will lead to more positive outcomes for those living with the disease. And Gráinne, who is our patient representative on the SYNERG-IE programme, she also co-founded Sjögren's Ireland after her own diagnosis with Sjögren's. She's been a volunteer on RCSI's PPI panel for Sjögren's for the past 2 years. Gráinne's background is as a senior occupational therapist with over 15 years experience working in hospital and community settings. Next we have Monika. Monika is a Sjögren's advocate and co-founder of Sjögren's Ireland. She's also a volunteer on our RCSI Public Patient Involvement Panel, and she's previously worked for several years with the Irish Migraine Society. I've lost Eileen. Oh, there you are. I was losing my notes. So Eileen lives in Dublin with her husband Stuart. She's passionate about people and works full-time as a HR business partner. Eileen joined Sjögren's Ireland as a founding member, and she's committed to raising awareness of Sjögren's in Ireland and helping build the community where Sjögren's patients and their families can feel supported and informed. So I think I'm going to start my questions first with Deirdre. And Deirdre, you have been an advocate for better patient care for quite a while now. Can you tell us how your journey started?
Yeah, I was speaking to a journalist from the Irish Times who was interested in writing about Sjögren's, and she did a great big article on it, and it was fantastic. And then you yourself reached out and asked if I wanted to speak about Sjögren's at a webinar, and it was the first webinar that was going to be centered around patients with Sjögren's, and so that was a big moment for me anyway, you know, and we kind of took it from there, and you roped me in then into organising the webinar, and which was a wonderful success. And then we realised that there was definitely a need out there for support, for community, for advocating that something needed to be done, and it was wonderful that we found researchers in yourself and Michelle and everybody else who are actually genuinely passionate and enthusiastic about making things better for the patients, that it wasn't just about the data and the clinical side, that you really, really wanted to get the patients involved. Yeah, and we took it from there, and here we are.
Can I ask you, how did it feel to be so public, to be the public face?
It was absolutely terrifying. And I think our health, particularly when we're unsure of it, particularly when we've been perhaps gaslit and had our symptoms dismissed, and you're even doubting yourself, to put it out there and make it public. We tend to deal with these things very privately. But I took that first step absolutely terrified. And then the feedback I got from so many people going, I feel the same, I've been through the same thing, I recognise this, and it was fantastic. Like, it was very gratifying and justifying, gave me a lot of, it fired me up to make things better and get people involved.
I have to say, we've been very lucky. We've learned a lot from working with the guys, and even from our very first event, we've learned quite a lot. And you can ask Deirdre during the break what the lessons that we've learned and how I've learned to not do everything all at once and try and make it slightly more manageable. Gráinne, I'm probably going to come next to yourself. So you joined as a founding member of Sjögren's Ireland and have a strong interest in research, particularly bringing the patient voice and perspective into research. Can you tell us a little bit about that?
Yeah, thanks. Thanks, Joan. So Sjögren's Ireland and RCSI have been collaborating together on Sjögren's research since 2021. And that's through the PPI program. And that stands for Patient and Public Involvement in Research. And what that means is that the patient voice is incorporated into all stages of the research process. So that could be anything from helping set research priorities together, deciding what questions are asked in a patient survey, or even at an event like this, saying we'll need a lot of drinking water for people with dry mouth. And then in terms of the SYNERG-IE program, you and Michelle asked us what matters most to patients, really. And we really emphasised education for healthcare professionals. I believe that's the single best way to improve patient experience. And later Maria will be talking about mental health, and it really is a great source of stress for patients when their healthcare providers don't know enough about this condition. We need to have access to healthcare professionals who have a depth of understanding about Sjögren's. Now, obviously, there are a lot of great clinicians out there, but we would like for everybody to at least have a basic understanding of the disease. There's a lot of misconceptions out there about Sjögren's, things like that it's rare, or that it only affects the eyes and mouth, or that it's not serious, and we know that none of that is true. For example, I was recently at an appointment with a doctor, and he asked me, "Oh, do you have Sjögren's syndrome or Sjögren's disease?" And I was like, "Oh, they're the same thing." And he looked at me and he said, "No, it depends on what part of the body is affected." So you sometimes wonder, doctors should have a better understanding, really, because it is a common condition. And then my job here is a patient representative researcher, and I was hired this year. Previously, I had worked as an occupational therapist, but I had to leave that role because of pain and fatigue associated with Sjögren's. And I'm embedded on the team, so that means that, like, on a day-to-day basis, that I can talk to the researchers about common patient experiences or what patients might prefer in the research. And alongside me then is our panel of PPI volunteers, and there's 10 of us in total, including the Sjögren's Ireland group. And we recruited that panel with, like, diversity and inclusion in mind. So we were thinking about, like, not only demographic diversity, but also, like, in terms of the disease. We have people who've had it a short time or a long time, and we tried to get a balance of experience. So I really hope that by sharing these range of perspectives, the SYNERG-IE research can be really strong.
We're going to move on to Monika. Monika, you have a special interest in the international Sjögren's community and making sure that Ireland is represented. Can you explain to us how that international community works?
Well, to start with, can you hear me? Going it alone here in Ireland is not an option. So being part of the international Sjögren's community is of paramount importance. We get the opportunity to share research that's being done internationally. We keep in touch and update each other on new information, and we also help each other by giving each other tips on how to treat various ailments, very often with non-pharmaceutical products. Anything to get us through the day. I'm sure you're all aware of that. We are part of Sjögren's Europe. This is an organization with 16 members. We work closely with Sjögren's Foundation in the US, and if you haven't visited their website yet, I would strongly recommend you do so. A lot of information. Sjögren's UK, formerly known as the BSSA, is another organization we keep in touch with. In October last year, Deirdre attended the annual Sjögren Europe conference in Athens. The topic was clinical research. Deirdre will this year once again represent us at the conference in Lisbon, which takes place in December. Clinical trials from design to participation and beyond will be discussed there. Last April, Joan presented a paper at the International Symposium for Sjögren's disease in Holland. The paper was based on an online survey with 331 participants. Joan very kindly also offered to represent us at the Sjögren's advocacy meeting, which was part of this event. Unfortunately, none of us could attend. Her poster, Joan's poster, one of 169, won the Best Patient Perspective Award, focusing on unmet patient needs, in particular mental health. The first ever award from the International Symposium was presented to Joan and the team from Ireland, a beautiful piece of glassware in the form of a teardrop. The award is here behind me. It's very small, but it's very pretty. And we'll leave it here, and you can come and have a closer look at it during the break. Thank you very much. Back to Joan.
Thank you very much, Monika. And I will say, all of the posters are inside behind the registration desk, so you can see the posters that were created. And there's also one that sort of covers a little bit about the short snippets of the advocacy journey. So do go and have a look during the coffee breaks. And I will say the poster was made with the team as well. It's not my poster, it's a group effort. And I might be slightly biased, but everything that got the guys the award was all of the stuff that they told us we should include on the poster. Everything that was important for a patient and the patient perspective. And that's what the judges, who were patients of an international consortium, that's what they said was really important. And that's what got you, the team, the award. So I know I'm slightly biased. It's like your favorite child, but yeah. So that I'm going to move on. I got ask Eileen a question there. So Eileen, you have seen the Sjögren's community in Ireland grow over the last number of years. and especially with the great work that the guys are doing across various different social media platforms. Can you talk to us a little bit about the Sjögrens community in Ireland?
Thanks, Joan. Yeah, I think it's testament that we're all here sitting in the room today, and we'd like to thank each and every one of you for engaging with us and, you know, coming together and forming this community of Sjögren's patients. And it's so important for us all to be able to be here and support each other. It can be a very lonely journey. I remember when I was diagnosed, I'd never even heard of Sjögren's, never mind met somebody who actually had it. So the fact that we're all sitting here together, sharing our experiences, is so important. And of course, we weren't the first to do this. As Gráinne mentioned, or Monika mentioned, Sjögren's UK through Breedine and Maeve have a group here as well. We'd like to thank them for the good work that they do also in supporting people here in Ireland with Sjögren's, and I know Breedine is here with us today. We have fantastic following on social media, and, you know, as the guys have already said, our aim is to advocate for everybody that's here today and to keep the Sjögren's at the forefront of people's minds and to spread the word. And, you know, big thanks to Gráinne for all the hard work on social media. You know, we have nearly 2,000 followers now across all of our social media platforms, which is a great achievement. And what we aim to do there is raise awareness, and we share some of the international content as well that we receive. You know, any kind of good tips and tricks that we find for dry eyes or other conditions we like to share. So it's about keeping people informed and giving people, I suppose, a place that they can go if they have been diagnosed and they'd like more information. We're working hard to bring your voice to the table, and, you know, this, Michelle, when she spoke about the SYNERG-IE project, it's a large part of that is the patient voice. And last year we were asked to speak at the Irish College of Ophthalmologists conference. They were doing a piece on the patient voice, and Gráinne very kindly gave that presentation. And part of that was we reached out to you through the WhatsApp group to get your perspectives, and we presented that slides with your patient perspectives at that conference. So we hope that, you know, we're bringing Sjögren's to the attention of healthcare professionals, of the community, and really just continuing to raise awareness and provide support for everybody that's living here with Sjögren's. With that in mind, a big part of the conversations on our WhatsApp group are around meeting, and it's great to have so many people here today with us, and so many people online as well. You know, we're delighted that you could join us. We're hoping to do a little networking at the coffee break. So in the room where you came in to register, you'll see some posters on the wall with Ulster, Munster, Connacht and Leinster. So we'd invite you to take your coffee and move to the area that represents you best, and maybe meet some new friends from that area, and hopefully you might be able to keep in touch or have a coffee together at some point in the future. But of course, you're all very welcome to mingle and get to know everybody, and of course there'll be lots of opportunity for that at lunch as well. For those of you joining online, as Nikki mentioned earlier, there will be a breakout room at the 11 o'clock break. So we hope that you'll avail of that and you'll be able to go and meet some other people with Sjögren's that you mightn't have had an opportunity to meet before.
Can I ask you, Eileen, what's the feedback been like from the community around the kind of the webpage and the various different bits and pieces? What have you heard back?
Yeah, the feedback I think has been very positive by and large. I think that, you know, just information is key, really, isn't it? You know, and there's a big hunger for information. So being able to share, I suppose, international best practice, international research, what's happening here in Ireland with research and best practice is really important, you know, and, you know, I think the fact that we have 2,000 people now following us, you know, is testament to the awareness that it's raising.
And I will say at the international conference, the guys were praised for sort of the information that they gave, that it's a credible source, but also that the tone, it's really positive, it's really warm and welcoming. Obviously, it can be scary, there can be, you know, uncertainty, but it seems to be kind of a positive place to go and join in the conversation. So don't be scared. If anybody hasn't already joined the WhatsApp groups, don't be afraid. Reach out and join. Can I ask Deirdre one more question? So we're here today, obviously, because of Sjögren's Ireland. Can you tell us how you established Sjögren's Ireland?
Kind of reached out initially through the BSSA WhatsApp group, which was fantastic. And the four of us here decided that, you know, we wanted to commit our time and energy into doing something, to making things better. And it can be very difficult when, you know, you have something like Sjögren's and you've all your day-to-day life stuff to try and then create an organisation on top of that. So we had to balance it between how much time and energy we had and how much ambition we had, because we wanted to do so much. And we were so lucky that yourself and RCSI gave us the means and the infrastructure to achieve some of what we wanted to achieve. And we've so many plans for the future as well. It's very, very exciting. So yeah, there was four of us got together and sat down and worked out a plan and decided, you know, what needed to be done. And our initial focus was on advocacy. We were like, we need to educate healthcare workers, we need to raise awareness. But so much of the feedback we were getting from people was that they wanted community, they wanted support, they didn't want to feel alone. And so that's why we created the WhatsApp group, which is fantastic. And those here who are in the WhatsApp group, you're an amazing group of people. And just the support that you give each other is just wonderful. And thank you so much for it. We couldn't have done it without you. You're such an important part of this whole thing.
I'm going to just ask one question, and any of you can feel free. So, how did you find coming in to RCSI, to working with the researchers and the academics and the clinicians? Was it what you expected? Was it different? Was any surprises?
It was so different from any other interaction I'd had with medical professionals. You know, with Sjögren's, it tends to be so negative, and you always have to go into hospital appointments kind of charged up and kind of, it can be quite an emotional experience. But coming into RCSI, all the researchers and clinicians, they're so open and so enthusiastic and so dedicated to actually making things better, to listening to us. And it's not telling us about Sjögren's, it's asking us about Sjögren's and asking us about our experiences and what we feel is missing and needs to be done. And that's hugely gratifying. And it's been just an incredible journey.
Just to add, if anybody wants to join the WhatsApp group, you can email us info@sjögrenireland.ie, if you live in Ireland, that is, and we'll be very happy to add you.
If anybody wonders what the name Sjögren's come from, does anybody know? Hands up. Oh, good one. It's a Dr. Henrik Sjögren, and he's from Sweden, but he's long dead now. He put everything together. I don't know the clinical terms how he did it, but it started with dry mouth and dry eyes. And you know, worldwide Sjögren's Day is on the 23rd of July, and Henrik Sjögren was born on the 23rd of July, 1899.
And if anybody's ever wondered how to actually pronounce Sjögren's, that was it, because Monika's Swedish.
By our resident expert. Okay, I think we're going to open up for questions. So we're going to try to have maybe 2 from the room and 2 from online. So I think there's people going to be roving around at microphones. So if you have a question for the panel, if you want to just raise your hand, the guys will come to your table.
And no questions are okay too.
Yeah, that's fine, because it's
You
going
can
to be...
chat at coffee break as well.
Okay, do we have some from online? No, fantastic. We're saving it all. We're saving it all for later. I actually would just like to say, on behalf of everyone here, I'd like to extend a heartfelt and sincere thanks to the incredible patient advocates on our panelists who've participated in today's discussion. Your openness in sharing your personal journeys with us has been truly inspiring and deeply impactful. You've highlighted the critical role that patients play in driving research. You've shown the importance of having Ireland represented and active at the broader national community. And thanks to the efforts of Sjögren's Ireland, who are 4 women who live with Sjögren's, who are volunteers, who started with a WhatsApp group. I mean, we're all here today because of them. Thanks to that, the group has grown. It's grown into an invaluable source of information and support. You're fostering community connections, raising awareness across the country and beyond, because we have had events attended online by people from as far, Mexico, Australia, and we've had a lot of international interest as well. I'd like to say that we are incredibly grateful for your time today and your continued advocacy and your commitment to making a difference in the lives of those living with Sjögren's. Thank you very much.
Next up, and thank you so much. That was just so informative, and it's just amazing to see all the work that's been done, and it's great to be able to collaborate with Sjögren's Ireland on the SYNERG-IE project as well, developing all the good work that's been done so far. Next up is Dr. Maria Gialama, who is a member of the SYNERG-IE team. She also has a psychology background, and she's going to deliver a talk now about supporting mental health in the management of Sjögren's. So thank you, Maria.
Well, good morning, everyone. Thank you so much for coming. It means a lot to us. I'm Maria. As Nikki said, and as everyone said before, I'm very excited to be here and to be a member of this team of multidisciplinary experts and experiential experts who share their lived experience, which is very important to us. And it's really also important to mention that today we are here because of the work of those amazing women who spoke about their lived experience and shared awareness. So a little bit about me, as Nikki said earlier, I'm a psychologist and I'm also a person who lives with a chronic condition, so I pretty much understand what it means to go through a lot of challenges. I joined the team with a view to exploring the experience of living with Sjögren's, and it is important to know what it means to different people because everyone has a unique experience. No two people have the same symptoms, and even if they do, which is unusual, their subjective experience varies. So we're here to understand and learn more from you. So today we're going to discuss, of course, the introduction of the interrelation between Sjögren's and mental health difficulties. We know that there is this interaction, and there are very many of them. Unfortunately, it is not possible to cover everything within 10 minutes. However, we will focus on those challenges that are most commonly found. And I'll try to keep it short, but I'm quite babbly, so just bear with me. And I'll be very happy to address any concerns and answer any questions later. So to start with, as we already know, mental health difficulties are very common in people who live with Sjögren's and can have a significant impact on everyday life. So everyone experiences Sjögren's differently, and the symptoms, as you already said, I'm going to echo you here, may vary from very mild to very severe. However, a good thing is that we have evidence-based approaches that can be used to improve those symptoms. This means that you can use whichever you feel is more enjoyable and useful to you, and not one size fits all. We have very many ways to improve our mental health. So the impact of Sjögren's on mental health, luckily, has been recently recognized by the most recent guidelines published by the British Society for Rheumatology and the European League Against Rheumatism. It is implicitly recognized, but hopefully we're going to get there. So the most frequently challenges that we are going to address today are cognitive difficulties that most people report that they're living with, such as brain fog and forgetfulness, anxiety, mood difficulties such as anxiety and depression, and sleep disturbances. So let's start with the cognitive difficulties, which are very common. Actually, they affect 1 in 2 people with Sjögren's. And when we say cognitive difficulties, we mean, for example, brain fog, which is a commonly used term, but it is very open to interpretation. So let's call it an umbrella term, which may include forgetfulness, such as, for example, forgetting a person's name, even though when you know them, and then the name comes to you later on the day. Experiencing mild memory loss, which may be unusual for a person's age, slow thinking or information processing, and challenges with planning, with organizing, or multitasking. What you can actually do, and this may sound as cliche or very counterintuitive, however, I'm going to say it, you can get physically and mentally active. But before you judge me, I would like to take a minute to share an experience with you. When we were preparing this presentation and we were finding such suggestions and recommendations, we were trying to understand how this could be easily implementable in people's lives. So we thought that instead of just giving people a very broad recommendation, such as be more active or do more X, Y, and Z, just try to find a few minutes, maybe even like 5 minutes, to start implementing small changes in your lives. So for example, when you you must be hearing that all the time, you must exercise. When you hear exercise, it doesn't have to be a 45-minute workout. It can be as little as 5 minutes. And you will say, like, what can 5 minutes do? They're not going to make any difference. However, you are starting to implementing small changes in your lives, and small changes can compound and build up to something bigger. So stay social is also very important. So you don't have to go out every single night with people and with your friends. Just a phone call, a few minutes of your life to share an experience, or maybe to share something that you may be finding challenging. This can make a difference as well. And practice mindfulness and relaxation. You may think that these are all very alien and it may not work for you, but studies suggest, research shows that they can be beneficial for a range of people who live with chronic conditions, because they can help you be in the present moment and become more aware of your own experiences. Anxiety and depression, unfortunately, 1 in 2 people will experience depression, and 3 out of 10 will experience anxiety, and these often coexist. This means that this can lead to intense and uncontrollable feelings of anxiety, fear, worry, and panic, that these may persist over time and interfere with daily activities. Recognizing, however, that you may be experiencing low mood for a long time, or if the symptoms become more severe, is the first step towards addressing those difficulties and seeking for help and support. And it is okay to do that. We know that there is this stigma around mental health, but once we understand that we're experiencing difficulties, it's very good to open to our GP or rheumatologist, or maybe a trusted person or healthcare professional who can help us navigate this and find a way to address those symptoms. So some simple action points that we can do. Again, practice mindfulness. It may sound as a cliche, but being in the here and now is a very valid place to be. We usually anticipate the future or think about past experiences, and we're getting caught up in these experiences. However, being in the here and now is very important, and we can become more aware of our own thoughts and feelings. Also, our inner dialogue is very important. The way that we talk to ourselves, the way we describe our own experiences, the words that we use. So how you speak to yourself matters. For example, if you're feeling anxious or if you're feeling nervous or stressed, you can just try and take some space and reflect on this experience and just try to replace I am anxious with I am noticing that I'm feeling anxious, and this somehow diminishes the power of the negative experience and gives you more space to understand and reflect on what is going on and process this and accept this emotion in a very gentle way and in a healthier way. Also, days may be challenging and there may be very many difficulties encountered. However, we can always find little things that went well and little positive things that can keep us going. Also, the third category that we would like to discuss is the sleep disturbances. Unfortunately, sleep disturbances affect 3 out of 4 people who live with Sjögren's, and they can be represented as not getting enough sleep or manifested, not getting enough sleep or waking up at night, waking up feeling tired or irritable, finding difficulty in getting out of bed, and challenges with coping with stress. So what you can do again is to listen to your body and be mindful of your own condition and your body needs. So instead of feeling guilty for having to decline a commitment or cancel an appointment, you just need to embrace your feeling. I know it's easier said than done. However, we just need to listen to our body. If our body needs rest, if we just need, as Monika and I were talking earlier, we discussed the fact that we do not necessarily need to sleep. Maybe we just need a few minutes to distress and decompress and take a breath. So maintaining a good sleep hygiene also is very important because it can help with regularity and the routine. And meditations that are specifically prepared for this, we have compiled a list of meditations. However, Beaumont Hospital has a very informative list which can help you, we will be sharing this later, which can help you navigate the beautiful world of mindfulness. We have additional resources for you in case you would like more information. Of course, you know best where to look for and where to look for support. Sjögren's Ireland is a fantastic organization and they're doing so much work and they're trying to educate us as well, which is very important. Insight Timer is an app that is used for free. You can download for free and you can practice mindfulness at your own pace from the comfort of your own house without really need to stress if you're doing it wrong or if you're doing it right. There's no right or wrong way to practice, and it takes some of the stress away. So the conclusions are that we need to acknowledge the relationship between the physical and the mental symptoms of living with a chronic condition. These can be intertwined, this can be multifaceted, and it's very hard to distinguish. However, this relationship is not very much explored, and this is something that we would like to do, and as part of the Sjögren's program, the SYNERG-IE program. Sjögren's can significantly affect mental health and quality of life, and if at any point you or someone you love and you care for may experience such symptoms, it's very good to discuss. It's very good to openly address those symptoms with someone you know. And importantly also, healthcare providers, as the lady said earlier, and Gráinne keeps reminding us that healthcare providers should be working alongside the person who lives with the condition and the persons who support, the supporters and the carers of the people who live with the condition, to provide holistic and personalized care plans. And those plans should be designed in such a way that would be meeting individual needs, those unmet needs that are very important to address. Do I have time? Great. So, yes, that's exactly how I feel. Thank you for that. Thank you for that. So before I go, I would like to share a poem with you because I think that it may be good to reflect on that and hear your thoughts later. It's by Becky Hemsley, and the poem is called Breathe. I'll try to do my best to convey the emotion. So, she sat at the back, and they said she was shy. She led from the front, and they hated her pride. They asked her advice, and then questioned her guidance. They branded her loud, then were shocked by her silence. When she shared no ambition, they said it was sad. So she told them her dreams, and they said she was mad. They told her they'd listen, and then covered their ears, and gave her a hug whilst they laughed at her fears. and she listened to all of it, thinking she should be the girl they told her to be best as she could. But one day she asked what was best for herself instead of trying to please everyone else. So she walked to the forest and stood with the trees. She heard the wind whisper and dance with the leaves. And she spoke to the willow, the elm, and the pine, and she told them what she's been told time after time. She told them she never felt nearly enough. She was either too little or far, far too much, too loud or too quiet, too fierce or too meek, too wise or too foolish, too bold or too weak. Then she found herself learning, surrounded by fears, and she stopped and she heard what the trees said to her, and she sat there for hours, not wanting to leave, for the forest said nothing. It just let her breathe. So thank you. Thank you.
We have some time for a few questions. If there's anybody in the room initially that would like to ask a couple of questions to Maria,
Or thoughts, concerns, feelings.
or any comments at all. It doesn't have to be a question. If not, maybe Michelle, is there anything online? Oh.
So we just have one comment, Maria, and it's kind of a question comment from Christina in Canada. So thank you, Christina, for
Hi, Christina.
joining us. And also, it must be quite early there, but just a comment around people with Sjögren's often experiencing exercise intolerance, particularly if they have dysautonomia. And I think we were talking about that yesterday. I think Eoghan will probably touch on that a little bit later. So just a reminder that it's very important for people to tailor exercise recommendations or any of these recommendations to their own specific circumstance. So I don't know if you want to comment further on that, but I just wanted to thank Christina for her comment and just share that with the room as well.
Yeah. Well, thank you. Thank you for saying that. And thank you for reminding ourselves that it's not, that's exactly what we were talking about last night when we were practicing and preparing the presentation, that sometimes when we hear exercise, we immediately think that I just need to be in my best form and run a marathon. Or these things do not exist, and these things actually do exist in a continuum. And when we say exercise, today I may feel like taking 5 minutes to exercise, but gradually I can improve, and I may take 15 minutes before I even know it. It's the same with mindfulness. We were discussing meditation earlier. So today, I may not be able to sit still for 5 minutes or for 20 minutes, but even a minute, even the consistency is that makes a lot of difference. So to get up and try to do something, even the smallest, the tiniest effort possible can make a big difference in the longer term. Just think of it as we are told that we just need to brush our teeth like twice a day for 2 minutes. Those 2 minutes do nothing. Literally nothing. But if we think about it, the frequency that we do it and the consistency, those things are that matter. So thank you for that.
That's great. And then just a follow-up question. I know we're not going to really touch on this today, but medications for anxiety and depression. So Maria was focusing today on the non-medications, and Owen might touch on it a little bit later. But the thing that we'd always recommend is that if you're not feeling okay, it's really important to get in touch with your GP or with your healthcare team, because, while we say people do experience these, kind of symptoms at different times, if you're not okay, please do reach out. And some of you may have been at the Sjögren's Europe event during the week, which focused on mental health. And I know one of the discussion points they had was reminding everybody, don't wait too long. Do be, do be proactive if you can, and try and just remember that, there's help available. But just, we always wait till the last minute to get things sorted. But it would be sooner, there as well. So I think we were probably down to time, I think, Nikki, at this stage, are we? There's a couple more questions just flying in now online, and a very kind comment thanking you for your poem, Maria. So thank you for thinking of that. We'll try and answer some of the online questions after the break, if that's okay.
Perfect,
just responding to people directly online. But thank you so much.
Lovely. Thank you so much.
Thank you to everybody so far speaking. You have made my job very easy because we are now to time and it's time for everybody to go have a coffee break. And as Eileen said earlier on, if anybody wants to meet people from their area, there are signs up on the walls for Leinster, Munster, Connacht and Ulster. I'm going to test on my geography now. So if you want to kind of try to meet people from your area, you're very welcome to do that. But please just have coffee and mingle. And we'll see you back after the break. Thank you. It's absolutely fantastic to hear all that chat, and I'm sorry for being such a killjoy and making you all come back in. But we'll have more time for chat and networking after Dr. Owen McCarthy's talk. So before I introduce Owen, I'd just like to let you know that we've left an evaluation form on everybody's seat. If you could let us know, this is how we improve things and when we know what we're doing well too. If you could fill that in. There's boxes at the back of the room and a box at reception as well for you to put the evaluation form in afterwards. We also have the front sheet of information about our research studies that are going to be starting really soon. So one of them is a project, a photography-based project, and then the other one is an interview-based study. So there's a little bit of information there in front of you. If you want more information or to put yourself forward for taking part, please get in touch. The email addresses of the researchers are at the front of those two leaflets, and there's two different studies taking place at the moment. So without further ado, I will introduce Dr. Owen McCarthy. He is a consultant rheumatologist at Beaumont Hospital, and he's also the clinical lead for the SYNERG-IE programme. So I'm delighted to welcome Owen today to talk about the treatment of systemic disease. Thank you, Owen.
Thanks very much, Nikki. And thanks very much to the Sjögren's community for inviting me to talk today. So when we were trying to kind of chat about what we would talk about today, I think Sjögren's Ireland had asked really to kind of touch on a couple of different topics. So I'm going to try and weave a little bit of a story over the next half an hour or so, if that's okay, really around kind of hydroxychloroquine or Plaquenil and the eye, because I know that has been a source of concern and variable advice is provided at times to patients. Kind of the treatment around some of the internal organ involvement associated with Sjögren's, and then just touching briefly on the future directions in terms of future treatments, and also the importance of clinical trials in the condition, because I think there's great progress being made, and I think part of the uniqueness and the specialness of SYNERG-IE is really the ability to raise awareness, but we then need to harness that awareness in terms of driving improvements for patients' outcomes over the next number of years. And I still, to this day, remember when myself and Michelle and Gráinne were meeting, just to going through kind of the interview pre the HRB, Gráinne kind of going, all I really want is a dentist and a doctor who've heard of this and can talk to each other, So it's this is kind of the uniqueness of what we kind of hopefully can actually change moving into the future in terms of increasing awareness about healthcare amongst healthcare professionals, but then also driving change through having potential options for patients and offering them therapies. So it's been an exciting year for Sjögren's. Firstly, I suppose in our own context, kind of really SYNERG-IE has begun to kick into life in terms of recruiting the staff, and certainly the ethics are going in. And there's been kind of real progress, I think, and a sense of momentum at our meetings over the last number of weeks and months that we're moving in a forward direction. But also one of the other really interesting develops this year is the British Society of Rheumatology has come up with a management guideline and updated their management guideline for Sjögren's. So as part of this, actually, we invited Liz Price, who is I think very well known in the Sjögren's community, to do a talk for us at the Irish Society of Rheumatology this year, really just trying to kind of increase awareness of Sjögren's amongst the rheumatology community and the treatment options. But rather than kind of being completely original, kind of, I suppose, and on the basis that imitation is oftentimes the best form of flattery, I have borrowed heavily from the guideline that the British Society of Rheumatology and Liz were key in developing for Sjögren's patients. So we are going to talk today about systemic disease, and I've kind of tried to anchor it a lot of the time around kind of what the management guidelines will be for, and what the advice is on this. So you'll see kind of little things like SOA, which is strength of agreement of kind of the people who are on the guideline creation, which included patients, rheumatologists, ophthalmologists, and things, in terms of just kind of the rationale and the level of agreement amongst the panel in terms of moving forward with treatment. So I suppose the first thing to do is kind of, are there ways to identify patients who may be at more risk of systemic involvement? And I think, like, from my own point of view, I think, you know, systemic involvement from Sjögren's is definitely under-recognised and, as a consequence, under-treated. But I think looking at the biomarkers or the particular potential predictors of this is important, because I think if you know these things, then it probably does make you slightly more vigilant in terms of, you know, kind of screening patients and being aware of potential new symptoms at an early stage. So I suppose classically, the positive Rho antibody seems to predict extragranular involvement from the disease, younger age of onset, ethnicity, males, and then patients who test positive for a rheumatoid factor. So it's kind of a signal that your immune system is probably a little bit overactive. And then the kind of the recommendation, which kind of, you know, I suppose a lot of this stuff oftentimes seems sensible, but it is always good to have it written down so that you can actually, you know, kind of formalize what you're going to do with your patients. And I think the recommendation is very much that that a thorough clinical and laboratory evaluation is done to inform the development of extragranular fevers and disease progression at every clinic appointment. And I think that's one of the really important features of, you know, making sure that people are attending their clinic appointments regularly with rheumatology or other specialties, so that you can begin to identify if something has changed over time. A lot of the time, some of our patients come in and, you know, we'll go through like a series of questions, and there may not necessarily feel like there's a rationale to some of what we're asking, but we are trying to work through has anything changed in terms of the development of new symptoms. And then we'll also update blood tests as well to see if there's been a change or a signal over time that anything may be changing. The other recommendation is again around looking for associated conditions that may be associated with Sjögren's, so that you can detect them early, detect the comorbidities, and actually improve outcomes for patients. So these are not necessarily specifically caused by Sjögren's, but a lot of the time you'll find that autoimmune diseases kind of hunt in packs. So oftentimes patients may have an underactive thyroid gland, they may have celiac disease. So what the recommendation is that from a patient perspective, that these tests should be done at baseline, and then potentially updated every 1 to 2 years to see if something has changed. And it also just provides you with the reassurance that kind of some of the general health measures that are key to improving anyone's health outcomes are being adhered to, in terms of making sure you're not vitamin D deficient, because that has a knock-on effect on your bone health, etc. And again, you can see the strength of agreement within the panel was quite high for that. So coming back to the kind of the treatment of systemic disease then, from my own point of view, you know, I think there's very variable estimates as to how kind of how common systemic disease is. I think, you know, certainly from my own perspective, I would see severe disease probably in more than 15% of patients. I think oftentimes, you know, we've spoken this morning about how even Sjögren's itself is under-recognized. So then you're kind of, you know, by the time you become, so then recognizing the importance of identifying systemic disease is even equally as more important once you secure the diagnosis, because the idea that it is just kind of dry eyes and dry mouth is a misnomer. in the context of today's talk, I'm going to talk a lot about kind of the most common organs that are involved, but obviously I think everyone in the audience will have a very different experience from this, and it can affect almost any organ in your body. But I'm going to talk a little bit about joints, lungs, skins, and skin disease in particular today, because those are the commonest ones. And again, the treatment's kind of cross-cut depending across a number of different conditions. So I think the first medication to talk about, and I think is hydroxychloroquine or Plaquenil. And this is kind of a medication that I think rheumatologists love, and we love it for a number of different reasons. But in the context of Sjögren's, it has been shown to be potentially beneficial for patients. One of the challenges that we have kind of putting a talk like this together, and actually when you're sitting in the clinic talking to patients, is that actually the amount of clinical trials that have been done to compare treatments for patients with Sjögren's are very, very low. And even in those trials, the number of patients that are oftentimes recruited to the study will be a very, very small number. So you could be talking about 50 patients, 25 given one treatment, 25 given a different treatment or no treatment, and then you're trying to see if the drug is effective. Whereas in the context of some of the conditions like rheumatoid arthritis that have had drugs licensed, there might be 1,000 patients in a study. So oftentimes people will find that the study that was done specifically in Sjögren's didn't show a difference. But a lot of the time, it's just there weren't enough patients to actually be able to identify the meaningful benefit that it might make for a patient. And I'll talk a little bit more about clinical trials later. But that being said, about Plaquenil, there have been some trials and more kind of registry studies in different parts of the world that have shown a benefit for patients. The Jocker study has showed a trend towards improved pain for the patients experience at 12 months. There's been a study that showed that patients seem to suffer less organ damage in the hydroxychloroquine cohort over prolonged follow-up. And then there was also an Argentinian study that showed lower prevalence of arthritis, fatigue, and skin rashes, and kind of markers that your immune system may be kind of overactive, or at least Plaquenil may be having an effect to dampen down some of the immune overactivation, called hypogammaglobulinemia. So that's just kind of your immune system being a sign that your immune system may be a little bit overactive. One of the things that you'll find in rheumatology in clinics is that we spend an awful lot of our time kind of learning lessons from one condition and then transferring that to another condition. And clearly, obviously, a number of patients with Sjögren's also will have systemic lupus erythematosus. And we know because there are much larger follow-up periods of patients who've been treated with Plaquenil in systemic lupus. But you can see there the benefits that have been identified from Plaquenil use in SLE. A lot of the time, I'm a simple person, but if you can have a drug that generally doesn't require a huge amount of blood monitoring or whatever, but has been shown to reduce disease activity, the risk of future flares for patients, to be able to reduce the risk of getting clots and severe infections, then that's a kind of a drug that we'll always be interested in talking to patients about whether they're willing to consider to take for their illness. And it's generally very well tolerated in that it doesn't come with the associated need for blood monitoring and kind of monitoring for infections and things like that. So some of the other treatments that we use to dampen down your immune system. So tying all that together, the recommendation from the British Society of Rheumatology, and I suppose someday, hopefully part of SYNERG-IE, we will have Irish-specific recommendations as opposed to having to borrow from across the water. But the recommendation at present is that in those patients with significant fatigue and systemic symptoms, to consider a trial of hydroxychloroquine for 6 to 12 months. So I think from a patient perspective, this is a medication that I think most patients will be offered at some point of their patient journey to see if it will help improve their patient outcomes. Now, one of the concerns, and I think Sjögren's Ireland had asked me to touch on this during the course of the talk, is around hydroxychloroquine and the eye, because there has been an increasing concern over the last, kind of since about 2016, when the American College of Ophthalmology kind of changed the screening guidelines, because there is a slight danger with hydroxychloroquine that the longer you're on it, it can begin to cause trouble with your color vision. And I think that is something that's obviously a huge concern for patients. What we know, however, is that there are certain risk factors that are associated with this. And really, it's the duration of exposure to the drug is the single biggest predictor. So if you look at the slide on the right there, you can see that that actually begins on the x-axis at 5 years. So the chances of developing any difficulties from hydroxychloroquine due to retinal toxicity within the first 5 years of being on treatment are less than 1%. Now, it does increase over time, but within the first 5 years of treatment, I think it's very low. And I think we oftentimes will see patients in the clinic when we start the drug, and we counsel everyone about the potential effects that hydroxychloroquine may have on the eye, but then they notice that there may be a change in their vision for another as they start the drug. And generally, that isn't a sign that the hydroxychloroquine is causing a toxic effect or potential damage on your eye. In terms of the other risk factors for this, being on the drug, as I've mentioned, for more than 5 years of risk factor, and then the dose of the medication as well. So generally, the recommended dose is now about 5 milligrams per kilogram. The maximum dose that anyone will ever be on is probably 400 milligrams. And I think what we know is that, and what we tend to try and do a lot of the time in the clinic is, if someone is doing well and feeling a little bit better, we'll try and drift down the dose of the medication, because it's a cumulative exposure toward the drug that actually begins to cause the problems. So if someone's doing well, we reduce it down, so kind of paying it forward to try and buy a little bit of time for the future if and when you might need it into the future. The other risk factors are if you have abnormal kidney test or kidney disease, that can sometimes kind of associate with the drug building up. If there are other drugs, particularly tamoxifen, that has been used in the treatment of breast cancer, and then if you've background eye disease as well. And that's really mainly on the basis that it's more difficult to screen. So coming back to what actually people would expect in terms of screening, or what they can expect when you start hydroxychloroquine, at a baseline, anyone who's starting the drug, we would normally send them on for an eye assessment. I think this is very helpful, and I tend to do it for two reasons. Firstly, I think it's important to identify that things are okay to be able to start the medication. In clinical practice, and the guidelines are, you can start the medication and refer them for the screening, so you don't need to wait to get the eye screening before you start the medication. The other thing is that obviously if you're seeing an ophthalmologist, they will also hopefully be able to identify if you have any other issues. They may be able to provide you with some advice about the managing of some of the sicker symptoms. So you may be able to get more value for your bang for your buck than just the baseline screening. So after that, then, if there's no issues and you don't have any associated risk factors that are more likely to cause trouble, it's recommended that you get your eyes checked again after every 5 years, and it's done annually after that. And that's done via kind of visual field testing, which is automated, and spectral density optical coherence tomography. So that's the machine that does that, and I can't explain anymore how that magic works, but there will hopefully be other people as part of the SYNERG-IE team that can. So I suppose the key things are, if you happen to have, if there's a question that there may be something abnormal on the visual fields, don't panic. I get my visual fields checked, and my own results are highly variable. They can vary with fatigue and things. The whole idea of the screening program is that they will begin to recognize something before before the kind of retinal pigment loss happens, so prevents the central vision loss. The tests can be variable, and it does vary. So they don't recommend that if there's a problem with the visual fields, that you stop it that day. They may actually request further investigations. Now, if the ophthalmologist tells us that they see signs of retinal toxicity, we will stop hydroxychloroquine. I think the other thing to be aware of, and one of the things that I actually learned putting the talk together, and it's always great to be invited to do these talks because you learn something yourself every time you do them, is that actually hydroxychloroquine can change your accommodation reflex when you start it for the first couple of weeks. So we do oftentimes have patients come into us in clinic going, oh, my eyes just weren't right when I started it. And I suppose the lesson to that today is, firstly, that isn't a sign that you're getting toxicity from hydroxychloroquine, that you can stop the drug that you need to immediately stop the drug and not reconsider it from the future. But also that accommodation reflex actually adjusts so over time. So I think really just kind of reassuring as much as possible that hydroxychloroquine is a really effective, a good treatment that helps a lot of patients, and the risks associated with it are quite low. just coming back to this slide here, even if you've been on the drug for 20 years and you've not, and when you've had an eye screen that's normal, like the absolute risk of getting a problem over the next year is still kind of less than 1 in 20. So we have patients who are on it for a very long time. The most important thing is that you're in the screening program and you're being observed for it. I think in Beaumont, we've had a screening program going for a number of years now, and we've only identified 4 cases, and none of them have actually had kind of central severe visual loss. We've picked it up before that has become a problem. So I suppose knowledge is power, and screening is really, really important. So coming back to talking a little bit more about the systemic disease, so because for almost any of the manifestations of systemic disease, hydroxychloroquine will be offered, but then oftentimes we'll look to add on therapy for patients as well. So as I mentioned already, kind of lungs, joints and skin are probably the most common manifestations, but it can affect any organ in your body. There are few long-term studies, and the studies that have been done are underpowered. And I think that's one of the most important things for the global Sjögren's community, is really about kind of, in terms of driving improved outcomes in clinical trials, is just recruitment to clinical studies. So in terms of the recommendations on behalf of the BSR as to what to do for patients who have systemic disease, I suppose we've already gone through hydroxychloroquine, but then they say that the systemic steroids, which I know a number of patients may have be offered, can be used in the short term to treat specific indications, but should not be used routinely in the management of Sjögren's. They say conventional immunosuppressive drugs are not routinely recommended outside of the treatment of specific systemic complications, and biologic drugs are not currently recommended. So that's an awful lot of no's, and it's kind of a bit discouraging when you begin to read those things. But I suppose the message for today is actually there's some really good treatments available. But what you need really is to have a very good understanding of what's going on with your patient to see how you can focus and target those treatments. So one of the other recommendations, and I think one of the unique aspects of SYNERG-IE really is that when we spoke to the HRB, we really kind of explained Sjögren's as a kind of a cross-cutting symptom that affects people with multiple autoimmune illnesses and will allow us to identify these patients at an earlier stage and introduce treatments for them. And I think this feeds into kind of the recommendation from the BSR, who kind of have said that in individuals with kind of Sjögren's and overlapping rheumatic diseases, for example, rheumatoid arthritis, SLE, or scleroderma, you should take into account all the confirmed disease entities when planning investigations and treatments. So a lot of what we do in rheumatology is kind of screen everyone, figure out what parts of which organs may be involved, and then we use treatments that we've good experience with in different conditions to try and guide improvements for patients. Because if you look at, we spoke about the difficulties of kind of licensed therapies and trials for Sjögren's, but if you look at the treatments that are available for rheumatoid arthritis, for SLE, for scleroderma, all of which are conditions that have Sjögren's associated with them, you begin to see that there's actually very good options. And you also begin to see that those options kind of cross-cut across the illnesses. So mycophenolate is a drug that we use a huge, Cellcept, Myfortic would be the other names of it, but those are drugs that we use an awful lot in scleroderma and SLE. You'll see rituximab that cross-cuts through rheumatoid arthritis, SLE, and scleroderma. So we learn the lessons from other illnesses. We learn kind of figure out the disease manifestations, whether it's predominant your joints, whether it's your skin, whether it's your lungs, and we have very good treatments that are available. And that's just a slide of kind of put things together going. There's really, there have been clinical trials that we borrow from that shown these drugs to be effective in kidney disease, in lung disease, in joint disease, and those are the treatments that patients will be offered when they attend the clinic. So very briefly, kind of talking through the options, I suppose the first thing to talk about is kind of, identification of the problem. And a lot of, again, what happens in the clinic is we're trying to figure out whether the patient today has active disease or whether there may be some other another problem going on. And I think if you were to look at the example, kind of moving back to the glandular element for a moment, we know, unfortunately, that the immunosuppressive therapies don't really make a difference for patients who've got very bad dryness. And the lesson of that really is that, that by the time someone is suffering that significant degree of dryness, damage has happened, and there isn't really a way for us to reverse that, sadly. So what we're so we don't really want to expose someone to risk in that setting of giving them the immunosuppression, because there's a risk, there may be a risk of infection. So it's all about us trying to find a balance of kind of risk benefit for patients, talking together as to what their hierarchy of needs and their concerns are the day you see them in clinic. So for patients with joint involvement, if it's predominantly kind of arthralgias, in the first instance, you may often be offered a short course of anti-inflammatories, but ultimately, I think you'd obviously be offered hydroxychloroquine. If there's a lot of inflammation in your joints, and when we assess you that day, you may be given a bridging course of steroids, but ultimately we would move on to offering you treatment specifically for those joints, so immunosuppressive therapy. And you'll see there, they kind of, in that line on the right, they just kind of go oral ID, which is an oral immunosuppressive drug. The guidelines don't actually recommend one above the other because there's so little clinical evidence, because there's been so few trials done in patients with Sjögren's. So what we do is we pull the evidence in from other areas such as rheumatoid arthritis. And in that case, the most common drug you'll be offered first line will be methotrexate. And then afterwards, if you still have residual joint disease, there may be some tweaks involved, but ultimately you will probably be offered either rituximab or a medication called abatacept or Orencia. Similarly for skin disease, again, this comes down to what type of skin disease we're seeing and the patient is suffering from in the clinic, whether it's kind of erythema, redness, but in the first line for that, usually you'd be offered topical steroids and hydroxychloroquine. But if it's actually kind of like inflammation in the small blood vessels and kind of and causing ulceration and things, we'll again probably offer people steroids to try and settle things down quickly, but then azathioprine, also known as Imuran, or mycophenolate or Celcept in that case. So trying to tailor the kind of the type of manifestation that people have, and then trying to and guide that in terms of the options. And likewise for lung disease, you'll oftentimes be offered steroids at the start, but we will always add in other immunosuppressive therapies on top of that to try and get on control, because we want to minimize the amount of steroids that patients are exposed to, because it does cause trouble in the long run. And again, the medication that is most likely to be recommended for that is mycophenolate or Celcept, and then oftentimes we'll add in rituximab, because we have evidence for that from kind of rheumatoid arthritis, lupus, and scleroderma. I think one of the other questions that is often asked of us in clinic is about the effectiveness of kind of natural pharmaceuticals in the management of the condition. I think the one thing that there's some evidence for is omega-3 supplementation. That's kind of not probably taking tablets. Unfortunately, it is actually probably through your diet, and that's generally oily fish. So very briefly now, I think I have about 5 minutes left, or else Nikki will kick me off the stage. I want to talk a little bit about the future, because the treatments I spoke to you about there, are very much kind of, we've been learning lessons from other conditions. They are effective, but really the future is about trying to tailor treatments to patients with Sjögren's. And I suppose the key cell that we're particularly interested in terms of being potentially associated in driving and causing these autoimmune conditions are B cells, which are set of cells in your body that kind of make antibodies and things that drive illness. I'm not going to, thankfully, because I don't have time, talk hugely around the kind of immunology, and there are definitely people better in the room with this than me, particularly Joan. But the B cell and the T cell talk to each other, and the therapies that we are people are exploring are really around trying to affect that. Some of them haven't been shown to be effective. So rituximab that I spoke about earlier, there have been issues with that. But I think really what I kind of suppose want to get across is that there are a lot of potential options in terms of the future, which I think is great. And I think the way of learning and kind of driving change in terms of the future for patients is actually the involvement of clinical trials. So we know that rituximab and abatacept have had clinical trials done in Sjögren's, and they'd really, in all honesty, they didn't show the outcomes that we would have desired for our patients. But that's not to say that they weren't important work for the Sjögren's community, because you really begin to learn the lessons of how you how you assess your patients in these scenarios from these studies. So even if trials fail, we learn lessons, and I think it's the importance of actually doing these studies. Is that firstly, like the the desire of all of us is that we find treatments. But even if they don't work, I think, again, kind of in keeping with SYNERG-IE, it's about learning and knowledge. And even within the Sjögren's community, people are beginning to learn that actually maybe some of the tools that we use to assess disease activity haven't been as effective at capturing improvement for patients as possible. So there are two main assessments that are done of patients in Sjögren's. The SDI, which kind of is a kind of a composite index. It has 12 different parts that you have to assess, and then in a trial you need to see it show improvement. But it's entirely possible for someone to get better in two of them, worse in one, and then that means that the trial that drug doesn't work for you, even though it may have made a really clinical, meaningful benefit for the patient. So how we explain and how we analyze these studies is really important. The other thing, the other indices is the ESPRI, which is really kind of a patient-reported outcome around how they're feeling in response to therapy. But classically, the Sjögren's trials have only begun to look at the ESPRI once they've identified that there was an improvement in the SDI. So a patient could be feeling much better, but if the bloody numbers don't add up on your SDI, that's not taken into account. And you learn that from those studies that didn't work. And I think, now there's been a vogue towards actually changing how some of the studies are designed. So you can see the classic study, and I'm not going to talk too much about the drugs, but I just want to give you the idea of actually, how people are being assessed in studies now. So the classic one was someone has a high SDI, which is they have high disease activity because of their lungs, their joints, whatever, and you have to show an improvement in that. But actually now there's an understanding that not all Sjögren's is the same, and there are different kind of cohorts of patients. So there are lots of patients who have very high fatigue and scores, and actually that can improve, but they may not have the huge amount of kind of inflammation that has to be objectively captured by a doctor. So they're now doing studies in those patients, and they're capturing that as a very valid outcome in terms of improving the patient experience. So they've learned to actually include different kind of cohorts or different groups in the clinical trials for the drugs. And we have I'm hoping before Christmas to have a trial open for Sjögren's in Beaumont. And one of the reasons why I picked the study when we were approached to it is actually it allows us to recruit patients into both these types of groups. The other thing is that they've begun to examine actually different ways of assessing the improvement. So not just relying on the SDI, actually looking at things like, is there an improvement in tear gland production, salivary gland production, and some of the blood indices. And actually, when you look at novel outcome measures, you begin to see that they can differentiate from the drugs that appear to have been ineffective in the previous clinical trial because the outcomes weren't sensitive enough to pick up the effect. So it's all about learning. So I think really I'm going to start wrapping up there, other than to say that there are some drugs coming through, and particularly in phase 2, and they'll be moving into phase 3 trials in the next couple of years. A lot of this is talking and targeting B cells, but it looks very promising in terms of a short period of time follow-up, 24 weeks. But certainly from our own perspective, it's very exciting that there are drugs, industry is interested in doing these studies, and that there are drugs that seem to be targeting B cells in particular that are effective for our patients. And there's more to follow in terms of getting through that and getting them licensed. So in conclusion, thank you very much for having me here today. I think, obviously, from our own point of view, I think hydroxychloroquine, Plaquenil, I think one of the key take-home points is a very safe medication generally, and it's effective as long as you're in your screening program. There are treatments available and effective in managing specific organ manifestations, and they will be discussed with you by your rheumatologist. But fundamentally, I think in terms of moving care forward for patients, active involvement in clinical trials, learning from those, and allowing those kind of those learnings to allow the licensing of therapies will be key into the future. Thank you very much.
Thanks very much, Eoghan, for keeping to time. We have about 5 or so minutes for questions. If anybody in the room would like to put their hand up if they have any questions for Eoghan, we'll take the room first. And I see this lady over here. Patrick will bring a microphone over.
Hello, Eoghan. That was very informative. Thank you very much. I suppose my query is about the progressive aspect of the disease. I was just wondering if you could say a little bit about that. If you have organ involvement, will that always progress, or is there a chance that that will stop? Or will it progress to other organs as well? Do you have any information on that?
It's very difficult. I don't think there's a real rule that we can follow in that, and that everyone's disease is just so unique. I think the one thing I would emphasize is that if there does appear to be systemic involvement, kind of getting on treatment for that early will lead to better outcomes for patients. So we, again, borrowing from kind of the evidence base from rheumatoid arthritis and from lupus and things, you know that if patients are treated early and treated aggressively early to get inflammation under control, then that actually leads to kind of improved outcomes in the long run. So what you're always trying to find the sweet spot for any patient in terms of not having to start medications too early in their journey, but not leaving it too late. And certainly we know that early aggressive treatment of systemic involvement in any autoimmune rheumatic disease leads to better outcomes in terms of controlling inflammation. So I think what I would say would be, in the vast majority of cases, if there does appear to be systemic involvement, start treatment. And then you can always begin to dial back over time if things are going very, very well. But from my own perspective, you know, the cases that I kind of not lose sleep about at nighttime, but kind of think that the kind of the regrets that I have is that, you know, sometimes someone has waited too long to start treatment and it just they've suffered damage maybe, and you can't make things better. So I think being very certain that there is active disease and it is definitely coming and will respond to immunosuppression is important. But then if that is there, I think starting the appropriate treatment early, getting things under control, and you can always reassess in kind of 18 months, 12 months, and if things are going well, you can begin to dial back down. That would be my advice. I think it's probably to start early and reduce as opposed to wait and delay.
Any other questions? Perfect.
Hi, thanks very much. That was so informative. I'm just wondering, would you come across many patients complaining of an itch when you see them in clinic?
Yeah.
And it's just wondering, like, I personally suffer from that, but not all the time. And I'm just wondering, when it comes, is it that you maybe have a bit of inflammation, or is there anything else that would kind of, you know, say why you get it some weeks and other weeks you wouldn't have it? And is there any treatment that you'd recommend for it?
There isn't, I suppose, there's no real rationale for why it happens some weeks and other weeks, other than I think when you're dealing with itch, the first thing, obviously, it can be so strongly associated with the dryness. So if there's an underlying flare of your Zika symptoms, specific to itch, I think the other things that are really important from a patient perspective are to make sure that that there are other conditions that aren't being missed. So there are things like iron deficiency anemia that can present with bad itch. There are one or two conditions that can affect your liver sometimes that actually are associated with very significant itch as well. I think in terms of managing it, then again, like it's kind of, I think it's probably important to paint broad brushstrokes rather than specific. But I think making sure like things like humidification and everything are kind of at a pretty stable level can be effective. And then it's about trying to manage things like an antihistamine would be the way to go. Yeah.
Right, we might take a couple of questions from Frank from the chat, and then we can come to the room again if there's more time.
Brilliant. So lots of great comments from the online chat. Couple of people had one question on Dee and Sandra both asked, how do people get involved or hear about clinical trials that they might be eligible to take part in? Is it through their clinician, or is there anything else people can do?
At the moment, it's very clinician based. You know, I suppose I have a background in doing clinical trials from when I was in the UK, so I've seen the benefits of this in terms of getting drugs approved for conditions like lupus. So I've always just been anxious to kind of have that as an option for patients in my own clinical practice, because I've actually seen the benefits of it for patients who appear to be refractory to therapy, to be able to offer them a clinical trial. At present, it's very much kind of centre-based, whether there are studies opening. I think, you know, I would be very optimistic moving forward that certainly I think there will be probably some clinical trials opening in kind of the Cork region as well. There is a clinical trial network for rheumatology that, you know, the trials are being offered to all the centres, but unfortunately it is very much clinician based as to what trials people do or don't want to do. It's all part of the importance of synergy, kind of raising awareness of the condition and the potential options.
Yeah, who's next?
Sorry. That was a great presentation, thank you. I just wonder, do you make any, you focus a lot on medication, do you consider diet as having any contributory benefits to Sjögren's?
Yeah, absolutely. And I think that, like, I suppose I've got to come back and talk medication straight away. But you can actually see there already, you know, when I was talking about the medications, like there was literally, like, you know, even for the medications, there was like maybe maximum 50 patients in some of the studies. So like the difficulty in providing advice to patients is this, that like the work just hasn't been done to be able to identify, you know, what the correct advice is. There's definitely, you know, a trend in a number of autoimmune diseases around omega-3 fatty acids being beneficial in terms of reducing disease activity for some of these. So if there's one thing to take, it probably is about a kind of omega-3. So that's kind of oily fish. Generally though, you know, it's hard to provide kind of evidence-based guidance just purely because there's been so little work done in the field for the patients.
One more question? Oh yeah.
I would like to know if Plaquenil can be taken together with a batch like Orencia.
So I think the question is, can Plaquenil be taken with abatacept or Orencia? It can be taken with any medication of those that I've talked about today. So really, what we have again learned from other rheumatological conditions is that you add on treatment, you don't really change that much. So for the example with lupus, everyone goes on Plaquenil and then you add on mycophenolate or Cellcept or rituximab. So unless there's a reason that someone can't tolerate it, we generally run the Plaquenil or hydroxychloroquine and then add on treatment. So there's none of the medications I spoke about today that you can't take Plaquenil with.
Perfect. And just another question here.
Just one last one. I'm just wondering if you have certain symptoms like lungs, for instance, how do you detect if your lungs are being affected? Is there an X-ray? Is there an MRI scan? Is there something you can have?
Yeah, I think this is all about screening. So I think the first thing is that's kind of some of what we do when it's all of what we do when we see you in the clinic on a 6 monthly or an annual basis is kind of listen to your heart, listen to your lungs, because oftentimes the earliest clinical feature you will find is actually you will hear some kind of crepitations or changes on listening to the lungs. In terms of screening, then. If someone has noticed a change in their exercise tolerance or something like that, you would do a set of pulmonary function tests, so a breathing test, and normally you would do either a chest X-ray or a CT scan. What would happen is that if you were identified as having lung involvement, normally that would be identified on the CT scan, and then in terms of monitoring your response, you may get a set of pulmonary function tests every 6 to 12 months to see if there's been any change over time.
Perfect. I'll just take one final question. We'll finish at that.
Hi, Doctor. Thank you. I'm just wondering if you've come across neuro-Sjögren's and if there is a definitive diagnosis for this. It's obviously neurology, but it is quite difficult to diagnose.
Yeah, and we see a fair bit of it. We have a large neurology centre in Beaumont as well, so it pulls people in from around kind of the northwest. So yeah, we see a lot of it. It can be notoriously difficult to pin down for some patients. It varies largely in terms of the presentation. So there are very, very different presentations of it, but it's absolutely an entity it can affect up to 5% of patients. The treatments that we spoke about there in terms of mycophenolate or rituximab are a lot of the treatments that we go to. So it does require close collaboration with your neurologists in terms of the diagnosis and often the investigation of it as well. Yeah.
Thank you, Owen. I think that's all the time we have for Q&A. So thanks a mil for everything. Welcome Eileen Sheehy from Sjögren's Ireland up for some closing remarks. Thanks, Eileen.
Hi again. Well, I'm sorry to say that we're coming towards the end of today's event. I really hope that you've enjoyed the day, learned something new, and made a few new friends along the way. Of course, this event wouldn't have been possible without the wider team and their support, and we do appreciate that it's a Saturday, and we thank everybody for coming and very generously giving us their time today. Of course, we have to thank our speakers. Professor Michelle Flood from RCSI opened up our event this morning and gave an overview of the SYNERG-IE project, which will run over the next 5 years. As you've heard, it's a very exciting and multifaceted project, which we hope will lead to better patient outcomes in the future. There will be an opportunity for you to get involved. Shortly, RCSI will be looking for participants living in the Republic of Ireland who are living with Sjögren's. We will be posting those details on the Sjögren's Ireland social media challenges, or you can sign up to SYNERG-IE as well for more information on those. Also, a big thank you to Dr. Maria Gialama, who spoke with us about our mental health. And I think the key takeaway for me was, to build it into our day-to-day, that small steps build into something much, much larger. And for anybody who may be suffering with their mental health, we'd encourage you, please, to reach out to a loved one if you can. But Dr. Maria has very kindly shared a list of resources, which we will share with you, and there's also some on our WhatsApp group as well. A big thank you to Dr. Eoghan McCarthy, who spoke with us today about the treatment of systemic disease and reassuring us a little bit, I suppose, about the use of Plaquenil and the screening that goes along with that, and more importantly, I suppose, the treatment options that will be there for us in the future. So we just have a small gift here for Dr. Maria and for Dr. Eoghan, just to say a thank you for coming to speak with us today. So if you'd like to come up just to accept this. We'd also like to thank Dr. Joan and Dromgoole for moderating our discussion earlier this morning and for being such a fantastic ally for those of us who are living with Sjögren's here in Ireland. So, Dr. Joan, we wouldn't be where we are without you. Thank you. A big thank you to the entire SYNERG-IE team who turned out today to support this event. You've been working tirelessly for us over the last number of months in organising speakers and bringing this event to fruition, and we really appreciate all the effort that you've put into making today a reality. A very special thank you to Alana, who went above and beyond in bringing this event together. Alana is the visual and interaction designer working on the SYNERG-IE team, and she's responsible for the fantastic posters that you see out in the reception area, and also the lovely social media posts that were shared about this event are all thanks to Alana's hard work. So Alana, thank you so much. There is a survey on the tables, and we'd really appreciate it if you could just take a few moments to fill those in before you leave. Your feedback is really important to us for things that went well today, for things that maybe we could do better, and suggestions for future events. So we really would appreciate your feedback if you can spare a few minutes. To those of us, or those of you rather, who are joining us online, we're going to say goodbye to you shortly, and we thank you very much for tuning in and your participation and questions today. Thank you so much. For those of you who are staying with us, we'd like to invite you to a light lunch, which will be served outside in the room where we had our teas and coffees. And before I let you go, I'd just like to ask the PPI panel if you could make your way to the front stage as well, just for a photo opportunity before we leave. So once again, thank you everybody for coming to share our day with us today, and we look forward to continuing our conversations at lunch.